I'm Dr. George Flynn. Welcome to In-Depth TV. And today we have two super special guests. Mr. Clint Cummings with the Memphis Medical Society. He's the executive director. And Dr. Jerry Thompson, who I've known for years and years. And he is with the Le Bonheur and University of Tennessee in otolaryngology.
Correct.
We're going to talk today about various things of medicine going on. And one of the prime things is opioids, and one of the prime things is healthcare economics. And so healthcare economics, I first heard a presentation by Dr. Thompson, and I was blown away by it. And so I said, we've got to have him on. And when Mr. Cummings said, okay, have him on, so we got both of them on. First of all, Clint, what is the Memphis Medical Society and what does it do, and just tell us a little bit about it.
So the Memphis Medical Society is a professional association for doctors. So much like some of your viewers might belong to Rotary, Lions clubs, or professional associations for their profession, the Memphis Medical Society is that for physicians. We do a lot of legislative advocacy in partnership with the Tennessee Medical Association, where we talk about things like healthcare economics, opioids, and other issues that are important to physicians and patients. We look for other opportunities to provide benefits to our members through a lot of different avenues. One of the things we have is a staffing agency in our office to help physicians staff their medical practices. And we provide a lot of other membership benefits just like any other membership organization would.
Good. Well, everyone wants to know about healthcare economics. Where we are, we had Obamacare. We've got some parts of Obamacare no longer valid. What's happened to people that are out there, our viewers, our listeners? What's happened to them and insurance? And everybody knows their premiums go. Why is all of this happening?
Okay. The one thing for sure is there is a lot of confusion, but let's go back to 1972. In 1972, healthcare was only about 3-4% of the gross domestic product, the value of everything made in this country.
Right.
When Ronald Reagan came in, he detected a significant change. It went up from 3 to 4 to 7, almost 8% of the GDP, and he declared it a national emergency. And so the greatest minds of all the institutions got together and came up with a healthcare plan, healthcare coverage, and they were called the Health Maintenance Organizations, HMOs. It was launched, the federal government supported it, just like Obamacare, but it didn't work. What happened was that it started out with a high moral ground, and then the gatekeepers started getting rewarded for preventing people from getting care. And the companies wanted to make more profits. And so it became very difficult for the average person to get good health care because it wasn't profitable to the company. Almost all the HMOs are gone. Puritan and Kaiser are the only ones still left. They're doing a great job. But that was the groundwork for what happened. Over the ensuing years, healthcare got more expensive. Healthcare got expensive because of technology. That's one of the reasons, because of inflation. In the 60s, we didn't have CT scans or MRIs. We didn't have the ability to take one drop of blood and do DNA testing and find out what diseases you may face. So there are tremendous advances that have occurred that were expensive. The training of doctors. My daughters just graduated. Each one brought with them $250,000 in debt. And so there is a great deal of expense associated with healthcare. And so a new crisis occurred. Now healthcare is 19% of the gross domestic product. It's bankrupting the country because you've got to make a decision. Infrastructure development, highways, buildings, the military, social issues, or healthcare. So there are going to have to be made some really tough decisions are going to have to be made. So the Obamacare theory was that they would find a way to produce low cost healthcare at high quality and fine doctors for not producing high quality and reward them for producing really good quality. And so the theory was that you could have an HMO set up, but instead of having it profit-oriented, have it set up on quality. All right? Obama said you could keep your doctor. Well, it wasn't true, because many doctors couldn't accept that extremely low rate of reimbursement. He said you could keep your insurance company. Well, that wasn't true either, because the insurance companies were not always offering a complete set of benefits that the floor of Obamacare required, so you couldn't keep them. It's probably not his fault, because there's 2,800 pages. I read it. Nobody else probably read it. So he probably didn't know the hidden consequences. But one of the consequences of it is that our healthcare system is very good. And there has been a significant effort to try to reduce costs. Only half of Obamacare was funded. And so the rest of the funding was going to come from savings from Medicare. Now, the way you get savings from Medicare, you're not going to deprive the elderly of healthcare. You'll have a revolution on your hands. The
Right.
Gray Panthers will tear down buildings. But what you can do is decrease what you pay the doctors in the hospitals. Well, we tried that with the GSR, where they were going to reduce this 20%. Well, this way, the way they're doing it is the currency of medicine. If you provide a service, the federal government back in the 60s determined a currency to judge what you do, and that is the relative value unit. And the House of Medicine would get together every year and determine the value of your work as a radiologist, internist, the value of my work as an otolaryngologist, and split the Medicare pie up based on amount of training, the amount of risk. The heart surgeons and neurosurgeons face more risk. The trauma surgeons face more risk, malpractice, and so they're compensated appropriately. Well, the federal government dissolved that group, and CMS, the federal government, determined the value of our RVUs. And they felt that our RVUs were overvalued. And so the surgery specialists were decreased, 7%. GI, same thing. Radiology in particular got hit. And cardiology was the worst. They were cut 47% on their ancillary services. And so that was the funding mechanism for the unfunded part of the Affordable Care Act.
Cut your cost. Basically, cut their cost.
Cut their cost. And so the problem is it was unsustainable. And so when we argued, the TMA had an
You're talking about the Tennessee Medical Association.
Tennessee Medical Association had an assembly where we debated the Medicaid expansion. And Medicaid expansion was part of Obamacare because they wanted to get 100% of the citizens of the United States covered. But to do that, they had to have the states go along with expanding their Medicaid. Tennessee was one of the states that didn't. And their argument was that it was unsustainable, that sooner or later there'd be a change in administrations, and all those promises to back fund all of the unfunded policies on the exchanges and other ways would never come to fruition or would end in 4 to 5 years. And it looks like that may be true. So right now we have massive confusion.
We do. And the challenge is in some counties, they're down to 1. In 1 or 2 counties, they're down to 0, insurance companies that will insure you. And so what have you seen from the, representing the Memphis Medical Society to the rest of the state? What do you see? Has anybody come up with a solution for any of this?
One of the things that they're looking at from a physician standpoint is something called a rural health partnership.
Right.
It's actually something that we work with a little bit, but it's a program of the Tennessee Hospital Association. So that's where they've tried to put more providers in those rural health communities. But the challenge with that program, as noble as it sounds and as noble as it is people nowadays, I guess millennials, if you want to call them, or people that are graduating medical school and leaving their residencies, they don't want to move to those areas. And these programs are set up to give them all kinds of incentives to do so, paying off their loans, giving them a high quality of life in that community, but it's been extremely difficult to get people to move there.
But we have seen a new model, haven't we, Dr. Thompson, as far as nurses, nurse practitioners, PAs? What is a PA versus a nurse practitioner? Because a lot of people don't understand the difference, and what can they do? What can these people do, and are they going to the rural communities?
All right. Let's break it down into three types of nurses. There's the nurse that doesn't have an RN. She has an RN but didn't do a 4-year program.
Okay.
You can get a BSN RN where you have gone 4 years of college and gotten your RN that way. So you can have a 2-year RN or a 4-year RN.
Okay.
And after 4 years of nursing school and college combined, you can get your registered nurse degree. If you take 2 more years, you used to be able to get a master's degree that would entitle you to be a nurse practitioner, either in a primary care setting, family medicine, or in one of the surgical specialties. But a few years ago, that changed. That 2-year degree, extra degree, is no longer a master's, it's called a doctorate. And so the nurse practitioners that are coming out of training now are called, doctors of nursing, right? They have everything except what we call a technical term, prescriptive capability. Prescriptive means under supervision is a better way to put it. So if you
Under physician supervision.
Right. And so if you don't have full prescriptive, you require a physician to write your narcotics for you and to supervise 1 out of 20 of your charts. They're not allowed to practice independently. In 19 states, they are. And so there was an effort of last year to get them full prescriptive, total unsupervised ability to provide care in the state of Tennessee. And that was delayed through negotiations for another 2 years.
Okay.
The latest change is one where the physician's assistants. Now, physician's assistants were people who went to college and then took an extra course, an extra year of courses. Now it may become 2 of medical training. They're not a nurse. They are a physician's assistant, and they work arm in arm with the physician. Well, many of them have gained a great deal of knowledge and feel that they should be able to practice independently too. So there is a new pathway where you've finished your physician's assistant's training, you take a 2-year internet course, then you practice with another family practice physician. You pass step 1 of the medical boards that we take, and then you practice again for 2 years with a family practice doctor, and then you can go into practice as a doctor of medical science in a rural community. And this effort was to eliminate the lack of medical care in rural communities. So there are 3 efforts afoot: the TMA in the legislature, the nurse practitioners, and the physician's assistants.
Okay, so we have another confusing situation. I can understand why patients are confused, doctors are confused, nurses, everybody seems to be confused with this. Let's go to one other area where there's really no confusion. There are no answers. Opioid crisis. Opioid crisis. Do we agree there is a crisis, or where did this come from? Do you have any insights into this?
Yeah, I think there's pretty consistent agreement that there is a crisis when it comes to opioids. There's no debating that. Too many people are dying in our state from opioids. So you've seen the governor come out with some legislative proposals to combat that crisis, because he nor anyone else wants to see any unnecessary lives lost to an overdose of opioids. So what you're seeing across the state is a debate about the best way to tackle the crisis. And doctors and those of us that represent doctors are always going to look at it from the best way to treat a patient. And one of the dynamics that's going right now is a 5-day minimum fill. Well, if you have had your shoulder operated on and need pain medication, typically that prescription is longer than 5 days. And so there's an effort to make some concessions and exceptions to that law, but There's a lot of different groups trying to solve the problem, and I think one of the challenges we're having right now is that they're all not talking to each other. Here locally, one thing that is going on in our county is there's a local opioid task force that does have all those players at the table. We have the health department at the table, we have EMS, we have law enforcement at the table, the Memphis Medical Society is at the table, the university is at the table, and so we have a local group of individuals that are going to try to combat some things locally that we have control over.
Well, from my looking at it and experience over too many years, right? I see it a problem with the supply side and the demand side. We seem to be really attacking the supply side, really, with carrot and stick. If you do this, if you do that. What's being done about the demand side, the treating the people that have the addictive personality? And in your practice, you have to prescribe some of these. What do you do? How do you know which patient's going to become rapidly addicted versus who can take the pills for pain and then just throw them away or put them somewhere?
Well, what we do is follow kind of a standard procedure, 5 days, and then we make a gut feeling, okay? When one patient is dramatically different than any others that we've seen in our practice, we get the feeling that this is an abuse situation. The typical thing is, oh, I spilled my medicine, or 2, I lost prescription, or 3, I took it all in one night or something like that because I needed it because of the pain. And so we hear those stories and they start to follow a pattern. When we see that pattern, then we stop the prescriptions and try to refer them to a pain clinic.
Okay, and a pain clinic. Tell me about pain clinics. What do they do differently than somebody else? Does either one of you understand the pain clinic concept?
My understanding is that we have to be cautious about using the term pain clinics because I think there are 2 categories in the world right now of pain clinics.
Okay, well that's important to know.
Well, and for lack of a better term, there's legitimate ones and ones that aren't so legitimate.
Right.
And I think the easiest way to find a reputable one is probably to ask for a referral from your current physician as opposed to shopping on the internet or shopping for your doctor in some other way. But the government's gotten really strict on those. They're also called pill mills, and the government's done a good job of being pretty strict on those. And I think that is kind of step one of our battle in the opioid crisis, and the other is kind of back to the supply and demand issue. There's a curbing of education that needs to occur. I think we were all given information 20 or 30 years ago or so, we being physicians, where, hey, these drugs are a miracle. You give your patients these and they don't feel pain anymore. Right. And now we're seeing the backside of that dynamic, and we're having to teach more physicians about alternative pain therapies. We're having to teach the public about, to even use, one of the things we're talking about on the task force is to even use the term opioid. Mm-hmm. Does the average person that's addicted to an opioid even know what that term means?
Right. Yep, that is a good question. What is an opioid?
An opioid is an alkaline compound that was originally derived from opium, the opium flower poppies, and now we can synthetically make it.
What are some of the synthetic ones that somebody, like you say, somebody out there may be taking one of these, not even know it? What would you consider one? We hear about fentanyl, we hear about, but what's so dangerous about fentanyl? We see so many deaths from that.
All right, fentanyl is a wonderful pain medication. We use it during surgery to help a patient wake up from the anesthesia without having high blood pressure from the pain and startle reflexes. The problem is that it produces not necessarily euphoria, but a relaxation, a pleasant relaxation, and people get addicted to it. Fentanyl patches are rampant. 2 dynamics that you need to know about. One is the number 1 cause of narcotic-related death is from prescription opioids, ones that have been prescribed by a healthcare professional. And number 2, the greatest concentration is in poor economic areas like East Tennessee. and inner cities. And so there's a demographic and there's a characteristic that tend to come into play.
Okay, so we have opioids. We sort of know what they are, and we have people taking them. Once somebody realizes they're addicted, what do they do?
Well, hopefully they seek help, and we.
I mean, or their family recognize it, or their physician. Where do they seek help? Where can they go?
We've got some resources here in the community, and that's another challenge of the task force that I mentioned earlier. So the university has one of the, or actually it is the only recognized center of excellence for addiction medicine in the country. So we have a great resource right here in Memphis. But of course, the challenge is from a hospitalization standpoint, there's a limited number of beds to do inpatient treatment. And we're also learning that even from an outpatient standpoint, we're running out of places to put these people. So one of the things that the task force is looking at is we need more resources in the community, because another statistic that you can easily look at to see the kind of situation we're in is there's a drug called Narcan that is used to administer to people who do overdose. EMS folks carry it. There's a lot of efforts throughout the country to let general members of the public access Narcan. Our EMS folks are running out of Narcan 3 and 4 months into the year. There's not enough money to pay for all the supply that they need. And you're getting that dynamic of people who are prone to overdose know that it's out there and available. They know they can be saved. So the Russian roulette continues with their drug use. So
I've seen around the country, some places have safe houses where you can go and inject, and they'll have maybe Narcan or maybe something. Is it making any headway here? And I see plus and minuses of that, but is anybody talking about that here yet?
Haven't heard anything about it.
Okay.
I don't see those here. I think what I see is that movement towards availability of Narcan. I believe it was in Mississippi. Several Krogers now are distributing Narcan in the state of Mississippi, and I think you may see a trend of that, of it just being more readily available, so that if the idea behind it is that if you know someone who's addicted and it's someone you love, you get the Narcan, so that the day you see them overdose, you've got it's equable to an EpiPen for someone who's suffering from allergies. So it's kind of a dangerous, bordering on morbid kind of thought to think we're just going to go out here and grab a quick fix for someone who's got a very chronic long-term drug issue.
Well, I've heard anecdotal stories where someone would give an overdose patient Narcan, and yes, it would save their lives, but the patient would wake up mad that you knocked out their high. I mean, I thought, my goodness, what's happening here?
Let's talk about the nature of a narcotic death. It's not magic how morphine, let's say morphine or fentanyl or anything else, how it kills you. It suffocates you. What it does is it suppresses the respiratory drive. And when your respiratory drive decreases, your oxygen level falls and your carbon dioxide levels go up. You don't feel the need to breathe. And you're very somnolent, you're sleepy, and you simply go to sleep and you don't wake up. And the Narcan reverses that effect in your brain and allows your brain to snap back on and start breathing for you again. The important thing is, if they're not breathing, in the ABCs, airway, of supporting someone and getting help there immediately. Because if you can save them from a prolonged period of not breathing, you can possibly save their brain.
So what you're talking about is apnea, and then the oxygen level goes down, you deprive your brain of oxygen, and then you get brain death.
Right.
So that is a bad way. Even though you save them, they may be brain impaired, brain dead. So it is, I'm glad you brought that up, because I think if people understand that, I think the more, like Clint was saying, the more education we have about what this can do to us, what this can do to people we love, it really puts a real impetus on getting them some care. Now, where to get care? Then we have the one center of excellence, and I believe that isn't that Dr. Sumrock? And
Yeah, Dr. Sumrock is
yeah,
the leader of that program.
Is the leader of the program. So, if anyone has any questions, can we put the Medical Society number at the bottom of the screen, and you can call the Medical Society and get referred to different areas, especially if you've got a loved one that you think may be having a problem here. It doesn't hurt to refer them. They're not going to be arrested. They're going to go and just see if they've got the characteristics and the qualities, and it's not going to, put a black mark on their record or anything. It's going to get them help.
I think it's important to note too that no matter how dependent they are and how bad you think it is, if it's one of your loved ones, these programs are highly trained and know how to wean people off basically and
Right.
do it in a healthy way.
It's not their first rodeo.
Right.
They've seen a lot of patients, and I know Dr. Sumrock very well, and he's seen a lot of people, and everybody says, my case is unique.
Mm-hmm.
Well, it's really not.
Right.
It's really not. He knows how to treat the worst to the early addiction to the middle ground, and he just knows. But what you said was, it's something about a gut feel. You can tell if that patient's going there or not.
Right.
And I just really appreciate the wisdom and the knowledge. And thank you very much, both of you, for being here with us. Any final words you'd like to say about anything that we've talked about today?
I think we could tie some of the conversations together and say it's important to monitor this legislation if you're a member of the public. I know it can be complicated, but it's important because one of the things to consider is doctors are some of our most highly talented people in the world, and they are entrusted to make decisions about our healthcare. And it's kind of the point that you both made earlier about that gut decision. That's an ability that if we're not careful with legislation, that can be taken away from them. And a lot of times it's in the best interest of the patient to let the doctor go with his gut feeling and not have to follow a set standard guideline, because each patient is unique, and it just makes for a better practice setting for the physician and the patient.
And that's one thing I've had a challenge with the not only the insurance companies, the CMS, the Obamacare. Every patient, they're trying to fit everybody into one mold, and it's one set of treatments for each patient. Each patient's different. The frontal sinuses may be in different places. They may respond differently to different medications. So every patient needs to be treated as a person, as a individual person, not as a number.
Exactly.
And I really applaud both of you, because I learned a lot of that from you. So thank you very much. I'm George Flynn. You've been watching In-Depth TV. And if you've got any questions, we've got the number at the bottom of the screen. The Medical Society, the Memphis Medical Society, is here to answer your questions. Thank you for watching. We'll see you next time.